and once I say go ahead, you'll be ready to go.
So people get in.
All right, can you see my screen?
Yes, you're good to go. We are live. We're going to hold just a second and let people jump on. Our count is going up, up, up. So yay, good morning. What's going on? What happened? I didn't touch it. Bob.
Something on that side.
I didn't even touch it. Well, why were you on there?
Because we're logged into Zoom, you just exit out of your Zoom.
Are we on?
No,
Yeah.
you were on.
Okay. Oh, they saw that?
No, they
Okay.
didn't see that.
Okay. We're live though, correct?
Yes.
Yeah.
It
All right.
downloaded the video on my laptop.
So just a few more seconds. We're letting people jump on here. Okay. All right, so I will probably have to,
I would go ahead and start.
yeah. So good morning, everybody. Welcome back. We're excited to have you back for our third day with our huge lineup we have today. We have 4 amazing doctors here to talk to us about our rare disorder of hypoparathyroidism. So I wanted to share an exciting thing that's going to happen after Dr. Levine's talk. You're going to get a pop-up on your screen and it's going to say, please take this survey. We did a little survey because of course we want to serve you as best as we can. So after Dr. Levine's, it'll pop up and we ask that you take just a few minutes to fill it out really quickly. And guess what else we're going to do? We're going to pick 5 random people who did fill out their survey, and they are going to get shipped this really cool brain fog t-shirt that was made by our very own fellow hypopara patient, Sherry Gaunt. So please take time after, it'll pop up after Dr. Levine's speech today, and we're excited to hear from you. So we are lucky this morning to start with Dr. Michael Levine, and he comes to us from the Children's Hospital of Philadelphia with the coolest little bow tie to talk to you guys today he's going to talk about genetic testing and hypoparathyroidism. So Dr. Levine, take it away.
Well, good morning, everyone, and thank you for attending this session. It will certainly be a little bit different. I hope that genetic testing for hypoparathyroidism will be familiar to some of you, but I think that the concepts that I'm going to discuss this morning and the mechanics about genetic testing will be relevant to many of you who may be interested in understanding more about genetics. I think that this will be a high-level course, but if you've got questions, please, we have time to go through them. I'd like to tell you I have nothing to disclose today that would represent a conflict of interest, but I would mention that, like other humans, I too have 23 chromosomes and 20 to 25,000 genes. So from that perspective, we're all in this together, and none of us should be conflicted about thinking about genetic testing. So here is what I'd like to cover this morning. 4 important points that focus on the application of genetic principles to understanding causes of hypoparathyroidism. But as I said moments ago, these principles really apply to evaluating patients with any genetic disorder. So we'll review some of the genetic studies that have revealed genes involved in PTH homeostasis, so controlling calcium and phosphorus, as well as genes that contribute to development of the parathyroid glands. And I hope by the end of my talk, I will have convinced you that genetic testing can provide a diagnosis for the patient. It can enable family screening that will identify other at-risk individuals who may not yet have developed hypoparathyroidism. And lastly, some exciting information that I'm sure you've heard over the past day or two about new and emerging treatments for specific forms of hypoparathyroidism. I believe finding a specific mutation can enable precision therapy using targeted treatments. So let's start with a clinical case that will put my morning's conversation into context. And here we can all play the role of the consulting pediatric endocrinologist as we work through this case together. This is a 4-month-old male with a history of fussiness and new onset seizures, certainly a very frightening and alarming presentation that will have parents and physicians highly focused. The baby was the first pregnancy for this young mother and was born full term. Mother took prenatal vitamins and reported that there were no complications during pregnancy or delivery. The baby passed all of the newborn testing, including the hearing examination, and the baby was discharged to home with mother and was fed an infant formula. And importantly, the parents gave the baby vitamin D drops every day, which are recommended during the first year of life for all babies, whether they are breastfed or formula fed. Now, the family history was interesting because the mother admits that she has occasional muscle cramps and tingling, particularly after exercising, but she doesn't think she's ever had her serum calcium level checked. The physical exam showed a healthy appearing baby with normal weight and length. There was no facial dysmorphology or unusual abnormal features to the baby's appearance, and the heart examination was normal. Tapping on the baby's cheek right in front of the ear elicited a very positive phosphate sign consistent with a low serum calcium level. Because the baby had had a seizure, he underwent a neurological evaluation. The EEG was normal and did not disclose a seizure focus. The brain MRI was also normal and without any structural defects. Well, here are the laboratory studies. After performing some biochemical tests, the comprehensive metabolic panel showed normal electrolytes, a slightly low magnesium level, a frankly low calcium level, normal alkaline phosphatase for age, and an elevated phosphate level. And every year we talk about the importance of measuring phosphate in a patient with hypoparathyroidism or suspected hypoparathyroidism, and how important this is to the overall evaluation of patients. Vitamin D status was excellent with a 25 hydroxy vitamin D level that was 35. And this is the major circulating metabolite of vitamin D. And if you want to know your vitamin D status, you need to know the 25 hydroxy vitamin D level. And the PTH level was frankly low, less than 15 picograms per ml. Now, what was really very unusual, I think, about this case was that despite having a low serum calcium level, there was plenty of calcium in the urine. And I want you to hang on to that thought. It's an important clue to what's going on. So based on the low serum calcium, the elevated serum phosphate, and the low PTH level, we've made a diagnosis of hypoparathyroidism. But what is the cause in such a young infant? Now we really have our work cut out for ourselves. Now, as most of you know, and only too well, the most common cause of hypoparathyroidism is surgical misadventure. The most common cause is total thyroidectomy, but even patients who have partial thyroidectomy or overly aggressive parathyroid surgery can develop permanent hypoparathyroidism as well. But if 75% of hypoparathyroidism is due to neck surgery, then 25% of hypoparathyroidism is non-surgical. And there are a variety of different medical and genetic causes for hypoparathyroidism. In some cases, this can be due to excessive deposition of iron or copper usually iron because of multiple transfusions, or excess copper because of Wilson's disease. And in some cases, cancers can metastasize and invade the parathyroid glands, decreasing their function. Magnesium problems are always something we're looking for. Very low magnesium levels can impair PTH secretion and action. And in some cases, magnesium levels can be so high that they trick the parathyroid gland into thinking that calcium levels are elevated, and this decreases the secretion of PTH from the parathyroid gland. Some patients have excessive burn injuries, and this can lead to a reversible form of hypoparathyroidism. And then, of course, some patients who have autoimmune disorders, such as Hashimoto thyroiditis or even celiac disease, can also develop antibodies that destroy the parathyroid glands and impair parathyroid function. And lastly, there are some patients who have inherited or genetic disorders that affect the parathyroid glands and can cause hypoparathyroidism. So as the consulting pediatric endocrinologist, what do you want to do next for this patient? We started calcium supplements and gave doses of calcitriol, the active form of vitamin D and the mainstay of conventional treatment of hypoparathyroidism. We also gave magnesium supplements because the patient's magnesium level was slightly low, but this had no effect on parathyroid function, thereby excluding a magnesium disorder as the basis for hypoparathyroidism. What to do next? Do we need more imaging tests, more endocrine tests? It's easy and straightforward to measure calcium levels in other first-degree relatives, such as parents and siblings, and I recommend this occur particularly when the patient is this young. But I think overall, it's most expedient to go to genetic testing in this child, especially with a maternal history that is suggestive of low calcium and hypoparathyroidism. What are other clues to help you suspect a genetic form of hypoparathyroidism? When hypoparathyroidism presents within the first few years of life in a patient, when there's a strong family history of hypoparathyroidism, and when there are other features that suggest a congenital syndrome that affects many organs or tissues that could include the parathyroid glands. This child shows many of the facial features of DiGeorge syndrome, included hooded eyelids, cheek flatness, a prominent bulbous nose, an underdeveloped chin, low-set ears with malformations. Many of the patients with DiGeorge syndrome will have hypoparathyroidism, and others will have an absent thymus, immune defects, and even cardiac defects. So we're always looking for kids and even adults who might have DiGeorge sequence as a cause of hypoparathyroidism. And we can also begin to suspect a genetic cause of hypoparathyroidism when there are no medical or surgical causes that might explain the hypoparathyroidism. So this is a slide that I showed to medical students and fellows in endocrinology who are in training, and I agree it's a complex slide. It shows most of the genetic defects that can cause hypoparathyroidism. But to simplify things, we can really divide all of these causes into three buckets. On the left are mutations that inhibit secretion, release from the parathyroid gland of biologically active PTH, including these two genes, the calcium sensing receptor, which hangs out here outside the parathyroid cell and which detects the level of calcium, as well as the gene GNA11 that couples the calcium sensing receptor to the signaling mechanisms inside the parathyroid cell. And this represents the calcium signaling mechanism. So mutations here can trick the parathyroid cell into thinking that calcium levels are high outside the cell, and this will reduce secretion of PTH. Now, there are also patients who have mutations in the gene encoding PTH, and this either prevents production of PTH or results in release of a PTH molecule that just isn't active. So this is our first bucket. Our second bucket represents genes that lead to destruction of the parathyroid cells. And this is typified by genes in this autoimmune regulatory gene that causes the APS1 syndrome, the autoimmune polyglandular system. And patients who have APS1 have hypoparathyroidism, as well as adrenal insufficiency and recurrent fungal infections. And then we have our last bucket, genes that encode proteins that are important for development or survival of parathyroid cells. And these include the master regulator gene of the parathyroid, GCM2. It includes an important gene that is missing in DiGeorge sequence called TBX1. And then these conditions will cause just hypoparathyroidism, but these genes lead to hypoparathyroidism and other features. So the complete DiGeorge syndrome due to 22q11 deletions, the charge sequence, the hypoparathyroidism, deafness, renal problem condition, HDR, caused by GATA3 mutations, and then these two genes that can cause the syndrome Sanjad-Sakati or Kenny-Caffey syndrome. So as you're considering genetic testing with your physician, I would remind you that genetic testing has many applications, and I'm a strong proponent of genetic testing. We can use genetic testing to establish or confirm a diagnosis of hypoparathyroidism or some other condition that we're concerned about. We can use it to screen families to find individuals who are affected but do not yet have symptoms, or we can use it to pick up carriers in a family who may not develop the condition, but who, if married to another carrier, can have children who have the condition. We can also use the genetic testing to determine prenatally if a fetus carries a genetic mutation that causes hypoparathyroidism. And we can use this for newborn screening. In a family where we know hypoparathyroidism is genetic, we can screen a newborn and thereby predict that this child will likely develop hypocalcemia and hypoparathyroidism. And we can also even use genetic screening for hypoparathyroidism as well as many other conditions once we know the genetic mutation to perform pre-implantation genetics. We can identify embryos created by in vitro fertilization that are not affected by the genetic disorder and can implant these into a prospective mother, and the baby will not be affected. And then lastly, knowing the gene that's involved and causing hypoparathyroidism enables us to proceed with precision treatment, allowing the use of specialized drugs that are designed to treat a specific defect. So how does one order and analyze a genetic test? Genetic tests can be ordered by any physician, not just geneticists. You and your physician should confirm that your insurance will cover the cost of the test before you order the test. Get pre-authorization. These are expensive tests, $1,000 and more in many cases. It's important to use a laboratory that has received CLIA approval, because only tests performed in a special CLIA-approved reference lab can be used for clinical decision-making. And then you really should speak to your physician about getting a consult with a geneticist. And this can be important for pre-test counseling, obtaining informed consent. So you know all of the implications of the genetic test. And then once the test result is returned, the genetic counselor can help you with the interpretation of the test. Now, certainly we're aware that genetic testing is often viewed as a gateway to the great unknown. And many people believe that genetic medicine messes with nature. And many are opposed to genetic testing for specific diseases. And yet I want to reassure you that genetic medicine is set to become one of the most important developments in healthcare, with advances in knowledge about the human genome affecting the treatment of common disorders such as diabetes, cancer, heart disease, and even hypoparathyroidism. So we have to follow the science. And here I'll put in a little bit of an aside about reminding you, if you've got hypoparathyroidism, that's an underlying risk condition. Make sure you're vaccinated against COVID-19. It's a safe and effective vaccine, and I haven't been paid by Tony Fauci to say that. Physicians have to help their patients deal with emotional fear and guilt about being the carrier of a genetic disease. There can even be social or family ostracism when someone's found to have a genetic mutation. And we all have to be aware that these tests can be expensive. So remember to get authorization from your insurance company before getting a genetic test. And there can even be financial and employment consequences of a test result. But happily, here's where your government has been looking out for you to address concerns regarding financial harm that might result from genetic testing that discloses a genetic risk. The federal government passed the Genetic Information Non-Discrimination Act, GINA, in 2009. This law was the first of its kind in the United States and is important because it was designed to protect individuals from any harm having had a genetic test. And again, as an aside, it represented true bipartisan legislative and executive collaboration, something I think we'd all like to see more of these days. So GINA prohibits group health plans and health insurance from denying coverage to a healthy individual or charging that person higher premiums based solely on a genetic predisposition to developing a disease in the future. And it bars employers from using this genetic information when making hiring, firing, job placement, or promotion decisions. But remember, it doesn't cover potential effects on life insurance, disability, or long-term care insurance. And you can discuss all of these implications with a genetic counselor before agreeing to have genetic testing. So now that we have an understanding about genetic testing in general, let's turn back to our patient and the genetics of hypoparathyroidism. And hypoparathyroidism can be inherited in 3 different ways: autosomal dominant, autosomal recessive, and even X-linked. And we'll talk about these 3 general mechanisms of inheritance in a moment. So this is autosomal dominant inheritance, and you can see here in the teal colors an affected father who has 1 normal gene and 1 gene with a mutation, and he marries a woman who has 2 normal genes. And in this case, the affected father can transmit an abnormal gene to either a daughter or a son. And you can see here, here's the abnormal gene from the father. And every child who receives 1 abnormal gene from the father will be affected. And the children who receive the father's normal gene and the mother's normal gene will be unaffected. So this is autosomal dominant inheritance. We see affected individuals in each generation. There's a 50% chance of each child being affected. Boys and girls have equal risk. Some examples of autosomal dominant conditions, high cholesterol levels, the BRCA1 breast cancer gene. In hypoparathyroidism, examples are mutations in the calcium sensing receptor gene that cause autosomal dominant hypocalcemia type 1, or mutations in GATA3 that cause hypoparathyroidism, deafness, and renal problems. Now, this is autosomal recessive inheritance. Both parents are unaffected, yet each carries one mutated copy of the gene and one normal gene. So in this form of inheritance, in order to be affected by a condition, you need two copies of an abnormal gene. So in this case, both parents are carriers, and there is a 1 in 25% risk that a child will develop the condition based on inheritance of an affected gene from both parents. And then 25% chance that a child will have two normal genes, and then a 50% chance that a child will have one mutated gene from mother or father, and they'll be carriers just like their parents. So here, if these two carrier parents have 4 children, one will be affected. So a 25% risk of being affected with each pregnancy. And common conditions that exhibit autosomal recessive inheritance include cystic fibrosis, but hypoparathyroidism can also be due to autosomal recessive inheritance, such as mutations in GCM2, the master regulator of parathyroid development, and patients with Kenny-Caffey syndrome or Sanjad-Sakati syndrome usually show autosomal recessive inheritance, with parents who are carriers and unaffected, and then 1 out of 4 children in a large family being affected. And then lastly, and the most confusing form of inheritance is X-linked. So here are mutations on the X chromosome. Remember that moms and other women will have 2 X chromosomes. Dads have 1 X chromosome and a Y chromosome. And when dad gives a Y chromosome to a fetus, it becomes a boy. And when dad gives an X chromosome, it becomes a girl. So XX is a girl, XY is a boy. Dad has that important role of determining the sex of the embryo and child. And this can be dominant or recessive inheritance, but there's one important point. Because dads do not give their sons an X chromosome, we never see father to son transmission of a condition when it's X-linked. And so following the inheritance pattern can be a little strange with X linkage, but it's possible. We do it all the time. And the best example of an X-linked condition that has affected a very large family that you all know about has been hemophilia, that has been involved in the royal families of most of Europe, from Germany to the Tsar to even in Great Britain. So let's turn to our next slide. And our next step is to address the nuts and bolts of genetic testing. And so several questions pop up at this stage. And again, good collaboration with your physician is paramount here. And let's take a look at some of the different kinds of genetic tests that are available, some of which you've heard about, either testing in your own family or testing of friends or neighbors, or even reading about these tests on the internet, or hearing about these tests on CSI or on Dr. Phil or something. So the first test is a karyotype, and this is the 50,000-foot approach to genetic testing. It's the oldest genetic test in our catalog, and what happens here is that all of the chromosomes, 22 pairs of autosomes, and the X and the Y, so obviously this is a chromosome set taken from a male. They're all spread out on a microscopic slide, and then someone looks under a microscope and tries to see if there are any obvious alterations in any of the chromosomes. And this can only reveal very large abnormalities. So a large loss or a duplication or rearrangement of a chromosome. This is a very crude test. And there needs to be a very obvious abnormality for this test to be useful. Now, the 5,000-foot view is provided by tests that use bits of DNA that are control, that are normal bits of DNA, and they're labeled with color. And these bits of DNA will bind or hybridize to specific target genes within the genome. So here we spread out all the genes, just as we did in the karyotype, but now we take this microscope and we add to the microscope slide a probe that is labeled with a fluorescent dye, so it glows. And here in green, we have a probe that will attach to the end of the long arm of chromosome 22. And in pink, we're using a fluorescent probe that binds to the DiGeorge syndrome area. And you can see it's bound to this DiGeorge sequence region on this chromosome 22, but you don't see a pink on this chromosome 22. So this is a positive fluorescent in situ hybridization, positive FISH test for DiGeorge sequence. And here you ask a specific question, is it DiGeorge sequence? You use the DiGeorge probe, and this is the kind of answer you can get. It's about one gene. You can also use a collection of DNA probes that are all labeled, and you can add this to a chopped up assembly of a patient's complete genome, and that's called a microarray. Micro because it's small, array because it's all of the genes. And here you can pick up a deletion or a duplication in any of the genes present in the patient. So that's a little bit better than a FISH test. Now, gene sequencing is the 5-foot view. So now we're at 5 feet, we can really see the genes. We can see the code of each gene. This is what they do on CSI and all the other forensic shows in order to identify whether DNA came from a particular person. They look at the actual code. There are 3 billion bases, so this takes a little bit of time and effort. But by sequencing, we can determine if even one nucleotide out of the 3 billion is abnormal. So we can use gene sequencing to analyze just one gene. We can ask, is the calcium sensing receptor gene normal or not? That's a quick test. Or we can order a panel of tests, a next generation sequencing panel for hypoparathyroidism that might have 20 genes on it. Or we can even interrogate the entire genome using something called whole exome sequencing. And here we don't have a clue what might be causing a patient's condition, so we sequence just about everything and then compare all of those sequences to normal and variant sequences in order to see if we can figure out where the defective gene is. Now, sometimes, and very often these days, we have about an 80% positive hit rate with genetic testing. We find a gene that has an abnormal sequence. And so what do we do then? We talk with the patient and remind them that there can be variability in that individual or even in other members of their family in how severe the condition can be. So some patients with hypoparathyroidism will have mild hypoparathyroidism. Some can have severe hypoparathyroidism, even with the same genetic mutation. So here, with the positive genetic test result in your hand, you'll need to discuss these results with your endocrinologist, and I hope also with the genetic counselor, because family screening may be important as a way to ascertain other individuals in your family who are at risk of developing hypoparathyroidism. So with this positive result, you've talked to your endocrinologist, you've discussed this with your geneticist, but we live in the era of the internet with access to tremendous amounts of information. Most of us also have neighbors who are full of all kinds of information, some of it good, some of it not so good. So where do you go for answers? So you could go to a textbook, but by the time a textbook is published, it's probably out of date. You could go to social media, Facebook, for example, but I would tell you that there's lots of bad information on social media. So it's probably not a reliable source for you. You could go to a friend, but really your friend knows about hypoparathyroidism and genetics. I think you could go to websites, but important to know which websites are reliable. This is what I think is the most reliable website. It is the online Mendelian Inheritance in Man. And I hope that my little picture in the upper right corner here is not obscuring the entire address, which is https://omim.org/about. And this is a highly reliable source of information. It's the gold standard for geneticists. Just about every genetic condition is listed here with good information about the condition and the gene. So this is, for me, the first place to look if I'm thinking about a genetic test result and a genetic condition. The NIH also offers a great website that lists all of the available genetic tests in the world and all of the laboratories that perform the tests. So you can help your physician find the laboratory to do the right testing. And there are great links to the laboratories that do the testing. You can find out more about the genes. And also, another great resource on this webpage is Gene Reviews. Gene Reviews is a highly useful website that has a very comprehensive catalog of reviews that are written by very authoritative sources. It's up to date, and there is a review for nearly every genetic disorder. These are expert authors, peer-reviewed, current information, and they also have links, active links that you can click on to patient resources. So going to the NIH website, Gene Reviews, reading that, you'll be linked to patient resources that can provide information at a very easily understandable level. There are also links to PubMed citations, and often patients come to my clinic with PubMed citations. What do you think about this paper? Do you agree or not? And there are also links to policy statements and even guidelines on how to treat these different genetic disorders. But let's get back to our young patient. So we did perform genetic testing. We first performed a microarray test, and that was negative for DiGeorge sequence. We then went ahead and ordered a hypoparathyroidism next generation sequencing panel that included 12 genes that are known to cause hypoparathyroidism. And bingo, we identified a mutation in the calcium sensing receptor gene. And this encodes the calcium sensing receptor on parathyroid cells and kidneys. This mutation causes autosomal dominant hypocalcemia type 1, ADH1, which is associated not only with low levels of PTH that cause high levels of calcium and low levels of phosphorus, but also because the receptor is also present in the kidney, ADH1 is associated with excessive excretion of calcium into the urine. And many patients, even young patients of mine who are 3 or 4 or 5, can present with kidney stones and renal calcification. And remember, when we looked at the initial laboratory test studies in this baby, one of the tests showed lots of calcium in the urine, even though the baby's serum calcium was low. This genetic test now solves that mystery. So now with this information, what are our next steps? Well, we've tested the proband, which is the first individual in a family with a genetic condition, and we detected a mutation. So we proceeded with testing the rest of the family. Dad had a normal serum calcium level, but mom's serum calcium was slightly low, and her genetic testing showed the same mutation in the calcium sensing receptor gene. So here we have confirmation of autosomal dominant hypocalcemia type 1 in both mother and son. And remember, future pregnancies by this mother will each carry a 50% risk of producing an affected child. Knowing that mother and son have ADH1 due to a mutation in the calcium sensing receptor now helps us. In addition to monitoring serum calcium and phosphorus levels, we'll also have to monitor serum potassium and magnesium closely. And remember, this child had a slightly low magnesium level on presentation, as patients who have ADH1 tend to have low levels of potassium and magnesium as well. So knowing the genetic condition in this family allows us to broaden our monitoring plan. We also know that we have to be extra careful to monitor urinary calcium levels, which are often very high in patients with ADH1 and can cause kidney stones and nephrocalcinosis, renal calcifications. And this can lead to renal insufficiency and even renal failure if we don't do a good job of keeping that urinary calcium under control. And lastly, identifying the calcium sensing receptor as the cause of hypoparathyroidism in this family gives us some therapeutic options. PTH and PTH analogs can help not only these patients achieve target levels of calcium and phosphorus in the blood, but can also reduce urinary calcium levels and reduce the risk of renal stones. And lastly, and what I think is really most exciting, emerging clinical trial data now offers hope that new calciolytic drugs, and I know you've heard the discussion about these from Dr. Gaffney, these new calciolytic drugs, which have been designed specifically for patients who have mutations in the calcium sensing receptor, these new drugs will represent precision therapy for these two patients who may want to enter a clinical trial. And when the drugs hopefully are shown to be effective and safe and FDA approved, patients with calcium sensing receptor mutations like these can be offered calciolytic specific precision therapy as a therapeutic option. All of this because of genetic testing. So my summary, it's important to consider genetic causes of hypoparathyroidism, particularly in young patients, and when there's no obvious medical or surgical cause for hypoparathyroidism. Genetic testing is available today. This isn't the future, this is the now. And most insurance companies do cover the cost of genetic testing. Gene panels that include many genes cost about the same as ordering a test for one gene. So a gene panel is a far more effective way to get a genetic test done. And a positive test result enables anticipatory guidance. It facilitates family studies. And even, I think the future will prove that these genetic test results will allow us to think more concretely about precision treatment of patients. And then lastly, genetic counseling aids understanding of risks and benefits. And so even before having the test done, seeing a genetic counselor is very important. So I'd like to thank you for your attention at this point. I see I've got a couple of entries in the Q&A as well as in the chat box. So I'm going to go and answer a couple of these in the next 15 minutes.
Dr. Levine,
yes.
Barry's going to ask you the questions for you so you don't have to search through.
All right,
Go ahead,
excellent.
Barry.
All
Welcome,
right,
Barry.
Good morning, Dr. Levine.
So I can't pick and choose the ones I know the answer to. You're going to ask me everything. All right, okay. I'm on the spot now.
You are. Well, thank you, Dr. Levine, for a great presentation on genetic testing for hypoparathyroidism. The first question we have here is, do you recommend a specific genetic test or panel? And second part, do you recommend all idiopathic patients get genetic testing if they haven't? Is there any reason for post-surgical patients to have the testing?
So I think it's a great question. There are several companies that offer panels. The University of Chicago has a genetics laboratory that has a very comprehensive panel. Prevention Genetics, Insight Genetics also offer excellent panels. And if you go to that website, Genetic Testing Resources, GTR at NIH, you'll find a list of all the different commercial laboratories that offer panels. So certainly think that's important. Idiopathic hypoparathyroidism, like every other idiopathic condition in medicine, means that the patient has pathology and the doctor is an idiot. Well, yeah, maybe I'm being a little bit, harsh, but idiopathic means we don't know what it means. But genetic testing is taking a lot of idiopathic conditions and providing causality. So once you know the gene, it's no longer idiopathic. So I think that every patient with idiopathic hypoparathyroidism should be evaluated using a hypoparathyroidism gene panel. So that's clear. You need to get a diagnosis if you've got idiopathic hypoparathyroidism. And lastly, if you have surgical hypoparathyroidism, there's really little need to do a genetic test for hypoparathyroidism. But I would add this. If you have surgical hypoparathyroidism because of primary hyperparathyroidism, it might mean that you had multiple parathyroid glands that were overactive prior to surgery. And there are genetic conditions that cause multiple gland parathyroid disease. And there are panels for that as well. And so you may not need a panel for hypoparathyroidism, but if you had hyperparathyroidism as the cause of the surgery that led to hypopara, then I think you should consider genetic testing for these forms of primary hyperparathyroidism that could affect other members of your family.
Okay. Thank you for that answer. Marcella wants to know, are there special considerations for breastfeeding in moms and or babies with hypopara?
That's an excellent question. I don't, I think we always in pediatrics remind patients and ourselves, breast is best. So we'd like every mother to breastfeed at least 6 months and up to a year if possible. There is a fair amount of calcium that will be transferred from the breastfeeding mother to the baby. So we would have to take care to manage the mother's calcium requirements. And she may see that there's an increased requirement for calcium. I would say also that pregnant women with hypoparathyroidism may require less calcitriol during the last few months of pregnancy because the placenta can produce calcitriol. So that's, not relevant particularly to breastfeeding, but to the whole pregnancy experience. And it's important for the breastfeeding mom to make sure that she's getting enough vitamin D to meet her own needs and to give that baby daily vitamin D drops in order to ensure that the baby has sufficient levels of vitamin D in their blood.
Okay. And you mentioned something about the COVID vaccine. So Becky wants to know, regarding the COVID vaccine, should all hypoparathyroidism patients be considered for the booster vaccine, including surgical?
Yeah, I think I would, in fact, because, you know, any patient taking an oral medication who becomes extremely ill and is unable to take their oral medications will require hospitalization. So we believe that any patient who requires a daily medication is considered in a high-risk category. And those patients should optimize their immune status. And in this case, it would mean taking a booster shot.
Okay, great. Sid says, if my family has 4 generational autoimmune diseases and I was assumed autoimmune hypoparathyroid since multiple AI, is there a test you recommend?
Yeah, so that's a great question. There is a test for the autoimmune form of hypoparathyroidism. It includes the gene called AIRE for autoimmune regulatory gene. It's positive in a great many patients, but not everyone. And it turns out that most patients who have a very strong family history for autoimmune disease, so celiac disease and Hashimoto thyroiditis, even some vitiligo, areas in the skin where the color, the pigment is lost, they probably have something called APS2, and we don't have a gene or genes for APS2 yet. So I would go with the APS1 gene, the AIRE first, and if that's negative, then I would sit down with the genetic counselor to discuss next steps. There are a number of research programs at NIH and elsewhere that are trying to collect families who have these autoimmune conditions throughout the family. And the NIH and other investigators are trying to find the genes that regulate the immune process in those families. So if the AIRE gene is negative, it may make sense to sit down with your endocrinologist and find out about studies that you can enter in order to contribute to the genetic information database.
Thank you. And I apologize for my dog barking. If you can hear that, she's going crazy. Okay. Dasha wants to know, what if you have a mutation that has yet to be discovered or recognized?
So I guess there's 2 parts of that question. Oftentimes we will discover a mutation in a gene that we know causes this condition. So you may have a new mutation in a known gene. And sometimes in order to understand whether that variation is truly the cause of a condition, we have to do functional studies in a laboratory to assess the effect of the variation on the protein. So sometimes functional studies are done. In other cases, we can make predictions. There are software programs that allow us to make predictions about changes in a gene sequence and whether it's likely or not that it's the cause of the condition. So that relates to a new mutation or a new variant in a gene that's known to cause a condition. And then there's the other part of that question, which is, what if I have a mutation in a gene that has not yet been associated with hypoparathyroidism? And that's where the real excitement comes from for most of us in the field of genetics who hope to discover new genes that cause hypoparathyroidism. And there again, we would do functional studies on the protein that is encoded by that. We might even make a mouse. We might even make a mouse that contains that mutation in that gene to see the effect of that mutation on the mouse's parathyroid function. So a lot of work to do, but really that's the dream of all discovery, to find something new. It's like Christopher Columbus going across the ocean.
Great answer. If you, Mindy wants to know if you were hyperpara first because of adenomas on your parathyroid, then become hypopara after surgery, would you suggest testing? And I think you touched on that, but
Right. So I wouldn't suggest testing for hypopara, but I might consider testing for hyperpara.
okay. And anonymously, someone wrote, do you mean, can a mom having hypoparathyroidism after thyroidectomy, not parathyroidectomy, have a baby with genetical hypoparathyroidism? So such a mom, should she take the genetic test before trying to be pregnant?
So if a mom doesn't have hypoparathyroidism and she has hypoparathyroidism because of surgery, it's unlikely that she has a gene that will cause hypoparathyroidism in her baby. Now, any one of us could have a gene that we could transmit that causes hypopara, and we could be carriers, just as some of us are carriers for cystic fibrosis, and we don't have it. But if we marry someone else who's a carrier, then 1 out of 4 of our children can have this. So there are some people who believe that all of us should have all of our genes analyzed when we're born, so that we have this complete catalog of risk. So I'm not there yet. I think we could get a lot more information than we would know what to do. So I wouldn't advocate doing all these tests in the baby because the mother had surgery. But I would, again, if it's a thyroid condition, some thyroid conditions are genetic. Mom could transmit that thyroid condition to the baby. And there are other conditions that we screen for, that are metabolic as part of the newborn screening. So, you can talk to your physician more about that. But again, if you have surgical hypoparathyroidism because of thyroidectomy, your risk of transmitting hypoparathyroidism to your baby is no different than my risk of having a child with hypopara.
Okay, and then I just have one last comment, and this is from Bridget. And she just wanted to say, Dr. Levine, thank you for your presentation. As someone who was diagnosed as a child in the 1970s, I appreciate the photo you showed of the 4-month-old. It helps parents today, and her mom didn't have anything back then to go by. Obviously, she's non-surgical. She was born with it. And she really thanks you and appreciates your presentation. And we all thank you. This was so very interesting, and we learned so much, and we thank you for being here this morning. Do you have anything else to add? Because I have no more questions here.
No, I think that.
Raise your hand.
Oh, sorry.
Yeah.
I have one more question, Dr. Levine. This is going to be from me personally. So I am post-surgical, but there is reason to believe I may have had hypocalcemic symptoms prior. My surgery was when I was young at 20 years old, and I was immediately hypocalcemic. I now have a daughter who exhibits hypocalcemic symptoms. Would it benefit us to get genetically tested?
Well, that's a great question. And I think I would first check your daughter's serum calcium level and her phosphorus level. And if those are both normal, then I don't think we couldn't make the diagnosis of hypoparathyroidism if the calcium and phosphorus are normal.
What if they are low normal? Like we've had that and the PTH checked because she does also have a multinodular goiter.
Yep.
And so they did check that, and her PTH was low normal, like right on the border, and her calcium tends to run like 8.4.
So that's subtle, and we'd have to look at the first. When PTH levels begin to go down, we see phosphorus levels go up, before calcium levels go down. So this is an example. It's a great example. And thank you for this question, because I discuss this with fellows and practitioners all the time. Endocrinology requires the examination of trends and relationships. So looking at just one calcium or one PTH is rarely helpful. So here we would look at the concentration of albumin, which is the protein that transports calcium in the blood, to make sure that the albumin level is not low. If a patient has a low albumin level, then their total calcium level can be low, but their ionized calcium level can be normal. So we want to look at the albumin, the calcium, the phosphorus, the PTH all at once, probably even throw a magnesium in. So if the calcium is a little low and the PTH is a little low and the phosphorus is a little high, then I think we are looking at potentially emerging or very early hypoparathyroidism. But remember, normal ranges are based on values in a population. And it's perhaps more accurate to refer to these as reference ranges rather than normal ranges. Why do I say that? Because the way that these reference ranges are established is you pull in 100 or 500 people off the street who say they're normal, and then you measure something in them. And let's say it's calcium. So you get 100 people come in, they get their calcium level checked. Now you've got 100 calcium levels. And if you put these on a chart, you get a bell-shaped curve, like everything else. The distribution is called a normal distribution. That's a statistical term, and it's a bell-shaped curve. And then what we do is we chop off the values, the top 2.5%, and we chop off the bottom 2.5%. And what's left is 95% of the patients. So in this case, it's 95 patients because we studied 100. And we see that's normal. That's the reference range. So what about those 2.5 people who had calcium levels that are a little high? Or the 2.5 patients who had calcium levels a little low, but they're still normal people walking in off the street. So that's normal for them, but it may not be normal if we only consider 95% of the population. So long story short, the more things we measure in any one patient, the more likely it is that we will find something that is out of the reference range. And if a patient doesn't have any symptoms of a condition, it's just as likely that that value is normal for them, even though it doesn't fall within the reference range. Just as likely to be normal for them as it is to be a true abnormal value that signals some disorder. So again, looking at the overall picture helps us put this all together. So if the calcium is 8.4 and the phosphorus is 6 and the PTH is 10, then that could be early mild hypoparathyroidism. But if the calcium is 8.4 or 8.3 and the PTH is 15 and the phosphorus is 3.5, I'm thinking this isn't hypopara. Even
considering if they have, I'll have to look into what all those values are, and I'm not asking you for a diagnosis, but would you also consider symptoms?
Well, the symptoms have to be the right symptoms, and they have to correlate with the calcium level. So this is one of the big problems in clinical medicine. Patient comes in, has symptoms, and then you give them a lab slip, and they go get a lab test 2 days later, and they don't have symptoms then.
Right.
What does that mean? So you've got to get the calcium level when the symptoms are occurring in order to put the two together.
I appreciate that answer. Thank you so much for taking the time to do that. And thank you for your wonderful presentation.
And Barry.
Super.
Thank you, Dr. Levine.
All
We
right.
appreciate you very
Sure.
much. We're going to take a 15-minute break and we'll see you shortly with Dr. Manstadt coming on. So we can't wait to see everyone. Thank you again, Dr. Levine. It was so informative
Thank you.
and
All
we
right. Bye-bye. Be well,
appreciate you.
everybody. Take care.
Thank you. See everyone soon. Bye-bye.